is Victor Armstrong. I am Director of the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. And it is my pleasure to be here with you this afternoon to talk about such an important topic. I do want to get right into this because you raised such important points throughout the different presentations. I want to start, if we can, with Dr. Kudler. Dr. Kudler, one of the things that was really intriguing to me in your presentation, when you talked about mental hygiene and the rationale behind mental hygiene, it just reminded me of the fact that when we talk about suicide, that I think oftentimes people don't understand that suicide itself is not a disease. It is the worst possible outcome of the culmination of a lot of very complex things, often including mental health challenges, but just very complex things. But that also, to me, says that there are opportunities to intervene, and there are things that we could do differently to intervene. And I'd be interested in hearing your thoughts, and as well as Dr. Strickland and Hassan, about what should we be doing differently in terms of intervening so that so many of our military veterans don't reach that point of suicidality? What is it that we seem to be missing?
No, thank you. Great question. By the way, it's so good to have you as moderator here. Thank you for joining.
Thank you. Thank you.
So yeah, we were taught, when I was a medical student, I was taught that suicide was impossible to predict, so don't worry about it. There's nothing you could do as a doctor to predict this. And if it happened, it certainly wasn't your fault. And I think this is a factor for doctors, by the way. We don't like to lose our patients. And I think we told ourselves a bit of a fairy tale for generations. Can't do anything about it. It's not your fault. Just turn a blind eye to the whole issue. Well, that was tragic. That was a mistake. We cannot predict it terribly well. I think I may even have misspoke during my slides. 38% of people who go on to die by suicide, or at least attempt it, have seen a doctor within a week, and the doctor didn't see that. Now, if it was any other health condition, and 38% of the time the doctor doesn't pick up on it, and someone dies, you know, there would be billions of dollars spent in research. What's wrong with you doctors and fixing that? The fact is, though, that, as I say, if they had a fever, if they had a blood test that I could check, if they even would answer a questionnaire a certain way, yeah, I would do that. And as a doctor, I have skills in doing that sort of thing. I think in most of these cases, they haven't really thought about it. Mm-hmm. But what is going on, and the reason they made an appointment, is they're not sleeping, they're anxious, they're having fights with their family, they're being told they're getting kicked out of the house. If they don't straighten up, they're drinking too much, they're using other drugs. And what do? I say, well, we got some great rehab programs, look at this literature. Well, and then within a week, it's 3 a.m. Mm-hmm. You had a fight with your wife, she slams the door, takes the kids, you're sitting there, you've been drinking, and you have a loaded weapon in your hand. There's no medical way for me to predict that, and there's no drug I can give for that. But what could I have done? I could have asked, when I met you 2 years ago, do you have enough income? How are you and your wife getting along? How are you doing with the kids? What job do you have? Anthony's number, 8 out of 10 people leave the military don't have a job. Do you have a good job? Do you feel like you're doing your best in it? Are you in school, but are you struggling there? So a lot of veterans struggle when they, even with all that wonderful financial support and the counseling. If I was tracking that stuff early on, I honestly believe I could make a world of difference. And for those 2/3 of people who aren't coming to VA, if I can work with their veterans benefits counselors at their colleges who are managing their VBA benefits, if I can work with the mortgage officers who are managing their VA benefits and pick up, hey, give them this literature when you see them, talk to them. Do you think they're in trouble? If you think they might be, hand them this card. I think that we could do a much better job. I think it's what we need to do. And I think we have to educate their families. Suicide is a frightening word and nobody wants to talk about it. But if we can detoxify the early conversation, if we can get people to be there, as it was our last slogan, and then make contact, reach out now, I think we can make a world of difference. They never taught me that in medical school, but I have sure learned it since then.
I think you just touched on something I see in the chat from Ray Martin's outreach to those who ask or self-report, or even family. The family reaches out, but what ways are we reaching out with no self-reporting out? And I think you kind of touched on that with asking those preemptive questions, and really, part of it just sounds like being curious and asking the tough questions that maybe an individual doesn't want to talk about, but they are the questions that could end up saving a life. I'd be interested in hearing if Dr. Strickland or Dr. Hassan, if you have anything to add.
Sure, I'd love to add. Thank you so much, Dr. Kudler. I'm trained as a clinical social worker, right? So as a social worker, we're trained to look at the whole picture. And so we're really working hard to integrate that kind of thinking into all disciplines and all levels of care at the VA, right? And you touched on something important, which is about building a relationship rather than just doing click boxes of, oh, you're okay, your blood pressure is okay, this is okay, but really building a relationship that allows you as the clinical provider to understand your patient, your veteran that's there with you. Whether you're a medical provider or a mental health provider or a friend or a teacher or whatever your role is with anybody, that idea that you utilize the tenets of motivational interviewing, which says, help me understand what it's like for you. Help me understand what your biggest struggles are. So there's lots of open-ended questions that really don't take a lot of extra time, but really open up dialogue and conversation with veterans to understand their situation and where to intervene. The other point I want to make is two points. One is nearly 50% of our veterans that die by suicide have not been identified by mental health, been to mental health, been engaged in any kind of care other than primary care for physical and preventative care, right? So that's a startling statistic. 50% are not identified with any other kind of condition that would warrant mental health care, substance abuse care, anything like that. The other point that I'd like to make is that 70% of veteran suicide deaths are by firearm. And so helping us have that conversation with veterans around safe storage, do you have access to a gun? And what do you do with that? And how do you manage that when things aren't going well in your home or in yourself or within your family? And that touches on how do we involve caregivers and families also in that discussion, because they're part of that family system.
Absolutely. Thank you so much for that. Dr. Hassan.
Yeah, just a little bit to add. So for me, it's always been about how can I build a trusting relationship with the patient population I'm focused on. So when I was on active duty, it was always important to be around them, to be trusted by them. When I deployed to Operation Iraqi Freedom, I had to live with them. I ate in the same DFAC tent. We'd work out with them. You'd have conversations with them. They began to see you as a person, not a therapist, not a doctor, and that was really beneficial. And I could see how these walk around conversations were extremely helpful. So that's why I think, having the Cohen clinics, being available, being present, being in the community, being culturally competent, being a trusted referred source matters. While 50% of those who die by suicide never make it to mental health, maybe they tried and we weren't there. And my thing is always, when someone raises their hand and they ask for help, if we're not there right then and there, we missed out. We lost that chance. We missed that opportunity. And I pay a lot of attention to that, and I want to continue to remind us that when someone asks for help, we need to be there. We need to remind them. And social media is really big now, and I see you do that all the time, Victor. Who knows what your messages are doing and how they're helping? But you know what? That's how we have to communicate these days. That's how we have to get the word out. So communication and marketing is really, really key here. So I say trust, I say access is really important. You know, at the end of the day, as clinicians, we may have lost the patient through death by suicide, and that's harmful and that's painful. And we do this kind of our own autopsy and look at what we could have done, what we should have done, what we didn't do. At the end of the day, though, I'd say this is a very complicated topic, and I don't think we can put our finger on one thing, and that's what we all struggle with. And while we want to be able to eliminate it, you know, it's hard work, and I want to remind people of that, because as clinicians, when we lose someone, we take up the heat, we get blamed, we feel the blame, we feel the shame, and we have to remember that this is complicated business.
Absolutely. You know, Dr. Strickland, you touched a lot on social determinants, and that's an area of real interest for me personally. And I spend a lot of time talking about the diversity, equity, and inclusion role in how we respond to suicide and how we respond to many of the challenges around mental health and stigma and things like that. And so I'm curious, as we're looking at and having a conversation about social determinants of health, I'm curious about that intersectionality, because one of the things that we sometimes lose sight of, I think, is that the world looks different from the perspective of a white male veteran versus a Hispanic female veteran. And that intersectionality of being not just a person living with mental health challenges, but a veteran living with mental health challenges, a veteran who may be a veteran of color living with mental health challenges, a veteran who may be a female veteran living with mental health challenges, a veteran who may be in the LGBTQ community living with mental health challenges. Can you talk a little bit about that intersectionality? And you also, in your response a minute ago, talked about the fact that 70% of the suicides are by firearm. And I'm curious if you have any stats on how that looks for female veterans who die by suicide as opposed to males.
Yes, thank you so much, Victor, for those questions. Absolutely. So to answer your last question first, yes, in this year's annual report, we saw a 12% increase in women veterans dying by suicide with firearms, using firearms. It's now up to 49% of female veterans' deaths by suicide are by firearm, which is up 12% in 1 year. So yeah, that's a critical issue. We don't have that broken down by race, but that's just the women issue. When you speak about special populations or diverse populations, we do see that our LGBT and trans veterans have one of the highest risks for suicide because of prejudice, discrimination, stigma, all of the issues, as well as their own internal struggles with family, social environment, those sorts of things. And so absolutely. In fact, we are just getting ready to launch some special projects targeting improvements and enhancements in our identification of our LGBT, trans, LGBT plus veterans and resources for them. We do not see an increase in, or we had not seen an increase in African-American veterans dying by suicide. It has been predominantly white men. Mm-hmm. However, COVID-19, the pandemic, we have seen suicide rates increasing among minority populations due to access to care, losing jobs, financial issues in the general population. And so we are concerned about any kind of intersection with our African-American veterans that is mirroring what's happening in the African-American community due to COVID and suicide. So those are some of the points of intersection and disparity there. And we are, another area is our Native American veterans. They actually have the highest rate of suicide. And we too are launching several initiatives to not only identify risk, but also to implement effective interventions within our tribal communities to reduce suicide risk and that sort of thing. So,
yeah, I appreciate you adding that last part, because that was something else I was wondering if you were seeing any infusion of interventions that do take into account the nuances of race and ethnicity and culture, and it sounds like that is starting to happen.
Right. In fact, right now we're funding a project with the Native tribal office and population around adapting. What are the cultural needs that we need to attend to adapt interventions to that population so that they're culturally sensitive and meaningful.
Very good. Dr. Kudler, Dr. Hassan, anything to add?
Just to say, historically, and again, you're taught in general training programs, women are more likely to attempt suicide and less likely to succeed. But that's because most women, other than veterans, don't use firearms. So the rate of suicide among veteran women is significantly higher, but that's because they use much more lethal means. I want to add, and it gets to something Dr. Hassan was saying, I'll throw out a hypothesis that go into a study about why more women are coming to the Cohen Clinic. I'm sure he and his team have thought of this already, is that women in the military are at great risk for military sexual trauma. I do not want to say that all women in the military suffer sexual trauma, but it is there is a horrible high rate of sexual trauma in the military. And then when those women go to the VA, they're often concerned that their records will be tapped into by command if they're still a Guard or Reserve. And it sticks with you even after you go to the military. You don't want somehow this getting back, or you don't want to be seen walking into the military sexual trauma clinic by people who served with you, even if you're already a veteran. And I could easily see why they would consider the Cohen Clinic a safer place. It will not turn over their records to command. I'm sure I'm right about that, Anthony. And we in VA use the Vet Center for that purpose. We tend to refer women for military sexual trauma counseling to the Vet Center because they are much tighter on their medical records. And also, frankly, the military doesn't know to go there to look for them. So that may be a big issue. And it's another factor in suicide, women who have suffered sexual trauma, especially, I believe, in the military. By the way, people who suffer sexual trauma in the military often have suffered sexual trauma before they join the military, and we're joining the military to escape from that kind of life. They're at higher risk for suicide as well.
I think, this idea of the Black, Indigenous, people of color, they have to feel like we understand, they can trust us, we need to be available. We try to do that with the veteran population. We want them to know that we understand their experience of their life as a veteran. We have half of our staff are veterans or military family members, people who work perhaps at the VA or within DOD. So there's a real good sense of understanding. And when that's missing, there's missing trust. It's very uncomfortable. And so we have to think about who we're serving and making sure that we look like and represent and understand in the way that makes our potential patients comfortable and trust. And there's trust there. We're getting ready to do this with LeBron James, and the I Promise School is primarily Black and people of color. And we're thinking about how does that look? Now there's a family trust. They call themselves We Are Family, and that's real. When you go there, it doesn't matter if you're white, Black, brown, yellow. If you wear that I Promise and you've kind of been brought in, your family and you're trusted. That's what we have to build within our clinics and our communities for people to really reach out and ask for help. It's so hard to ask for help, but to ask for help when you're a person of color, it's even more complicated.
Absolutely. And Dr. Hassan, when you talk about the Cohen Network, one of the things that comes to mind to me is I'm a huge proponent of peer services and peer-run centers and peer respite centers. And this sounds so much like a peer type service because you're receiving service from people who understand where you've been, who understand your challenges. Can you talk a little bit about just the benefit of having that connection? Because so many of us, as much, and I think the video that we saw really spoke to that, there's so many of us think that we are talking to and speaking to and relating to veterans, but don't even realize sometimes that what we're saying is really not being received in the way that we intended, because we don't understand, and they know we don't understand.
Yeah, I kind of said it earlier, it's, you just have to have a place that makes them feel when the moment they walk in, like, oh, I get it. So if you go into a Cohen Clinic, you will get it right away that this clinic is part of that community. This clinic is part of the military community because of the decor. It's how people greet you. It's people who wear an ID that says I'm a veteran of the Army or Air Force. It's that quick recognition. We see a lot of our patient experience surveys, and the anecdotes that we get from them are things like, it finally felt good that someone understood my experience. I finally someone appreciates that a military spouse's life is different than a truck driver's spouse. So again, it's what we do, it's what we say, it's how we say it that builds the trust. And it's hard to explain, I think. It's easier to feel. And when half of the building is made up of people who've served or have been around those that have served, it's a feel. And I wish I could explain it more and give you all the details, but it's walking in a room with people who look like you, talk like you. It makes you feel different.
Yeah. So how do we, and I pose this to all three of you, two questions. One is, as a lay person who wants to support the work that you all do in supporting our military veterans, how would you advise someone to get involved and to be able to offer that support?
Well, veterans are invisible in our waiting rooms, whether we're the Motor Vehicle Bureau or the or Mental Health Bureau or Family Court. Veterans are invisible, and so are their families. And I think finding ways to make veterans visible. We're still trying to make veterans visible in the UNC health system. We're still trying to make them visible at Duke. Of equal time on that. And they're not. And but to make them visible, when we started the governor's work group a long time ago, we trained for the first time the operators on VA the Carolina call-in system for help from any state issue to ask, have you or someone close to you served in the military? Are you calling about a service member or a veteran? And we found out that a tremendous number of people were. And when we tracked where were these people calling from and what were they calling about, for like 8 years that we tracked this, the most common place they were calling from is Medicaid. They were asking, how do I get Medicaid for my family? We never put, and we still, I don't think, have put Medicaid training, let alone VA outreach people in the Medicaid offices, because apparently that's a good place to find these people. Family court's another place, but we didn't know that, but we found that out. So I think making veterans visible and teaching that intersectionality. I might be on my way to jail or prison. I might be on my way to get a marriage license. I'm invisible. And what could be more natural than saying, by the way, have you or someone close to you served in the military? Oh, Well, thank you. And did you know about this? Or I have something to give you, or how are you doing? And take them 5 minutes.
Yeah, absolutely. Thank you so much. Dr. Strickland.
Yeah, that speaks to the Ask the Question campaign, which a lot of Governor's Challenge teams have as one of their action items, is to infuse Ask the Question on state forms across state agencies and that sort of thing. So that's definitely one thing that can happen. But it speaks also to the larger community, as lay people, right? Not only do we have to identify who's a veteran, but also just to create communities that are engaged and inclusive, include everyone from family, from age children to old folks, to different races, inclusion, and then be able to build support systems within communities that reduces stigma, right? And so one of the big things for anybody, and especially our veterans, is reaching out to get that help because of stigma, whether it's internal stigma of, well, somebody else needs this more than me, or I could face negative consequences as a result of reaching out. Or if it's public stigma, people are going to think differently of me, or people are going to judge me harshly or in some negative way. So we have to combat that and make it a normalization that we all struggle, we all hit the wall from time to time, and that we're there for each other in a compassionate, caring, open, non-judgmental way.
Very good, thank you. Dr. Hassan, anything to add?
I think I forgot to mention that, if you're a clinician or a staff member and you don't have any experience, there's military cultural competency courses that help you speak the right language, use the right words, understand the experiences. We did a survey, a Harris Poll survey, and thank you for your service. And believe it or not, many military men and women are uncomfortable when people thank them for their service. And so, in other words, people would rather have you ask, veterans would rather be asked, to maybe speak about our time in overseas in Germany, or living overseas in Japan, or tell us more about your job. What did you do in the military? And so trying to create a conversation that's not about war, it's not about deployments, and it's not just about thanking them, but really try to get to know them.
That makes so much sense, and I appreciate you sharing that piece, because I think it applies in so many ways. If whatever the population is, people don't always want to be reminded of why they are marginalized, or why you see them as marginalized. They would much rather talk about other things. So that makes perfect sense. I think that we are out of time, so I'm going to wrap this up, but I do just want to give you, I want to give you all the final say. If there's anything that we have not touched on that you would like to put out there, you want people to know, I'll give you the opportunity to do that, and we will close out on that. Let's start with, it looks like Dr. Kudler, your mic is already open, so let's start with you.
My mic's always open, I'm afraid. So one of my hopes for the next few years is VA has just recently created something called Smart Start, where they're going to start working with military members 6 months or so before they leave the military, and ask questions like, do you have a job? Things Anthony identified. I am hoping that we will be able to get VA and DoD to work together to add a very brief well-being survey, well-being being the social determinants of health. Do you know if you get a job? Are you financially secure? How's your family doing? And then we can build into that Smart Start thing, which will then continue to follow them at a regular schedule after they leave the military for a while, and do some social prescribing. You said that you didn't have a job. Mm-hmm. Well, you tell me you're going to North Carolina. Let me link you to NC 360, and we're going to get you job help through this network we have. I'm really hopeful that we can begin to develop a system like that looks beyond, are you do you have a mental illness or not? If you do, I'm getting you an appointment when you leave, which you won't keep very likely. Rather, do you have a job? Things people want. You know, I believe we can get there. And the tools are just now being developed and validated to do this in a practical way.
Good, thank you.
I'll go. So my hope is that you all continue to do all the good work you're doing and partnering with the VA there in North Carolina to support and to help collaborate with you and partner with you around all of your efforts in reaching veterans wherever they are in your communities. The other thing I want to make everyone aware is we'll be launching 988, which will be the new crisis number next July. So as soon as we get all that ready, we'll be blasting that out. But 988 will be a great resource for everyone as you deal with helping folks that are in crisis. And then, still continue to move forward the lethal means safety messaging. No one wants to take away anyone's guns. We just want people to have them safe when there's a crisis at hand.
Absolutely.
Thank you.
Thank you.
I would close by saying, you know, and this is of course coming from a veteran, but love our military. You know, they're on watch. They were on watch yesterday. They're on watch today somewhere in the world. And they'll be on watch tomorrow as we sleep and wake up. I think we need to be on watch for them when they come home. And of course, on watch for their families. So thank you for giving me this time to share today.
Well, thank you so much. I want to thank our presenters, our panelists, Dr. Kudler, Dr. Strickland, Dr. Hassan, for sharing such brilliant information with us, for such engaging conversation. Thank you for the work that you do every day. Thank you to the Governor's Institute for this event today. I want to thank my own personal military hero, Jeff Smith, who works here with us at the department, for inviting me to be a part of this conversation. And I want to say thank you to everyone who tuned in to watch this, and thank you most of all to those who have served our country, to our military veterans and those who continue to serve. Thank you so much for all that you've done. Thank you so much for all that you do. We could never repay you for all that you've done for us and for this country, but we do say a collective thank you.